Hello, I'm David Kerr, Professor of Cancer Medicine from University of Oxford. What I'd like to do is to talk a little about a patient that we've been looking after and to link that to a recent interesting publication in Lancet Oncology. I'm sure those of you who are watching who are clinicians have had from time to time recourse to look after patients who come from prison, often with guards, often handcuffed, adding somewhat to the complexity of the treatment that we offer. It's interesting, I sometimes find myself tailoring treatment so that we can be sure that the treatment's delivered, so that we can be sure that there are no accidents, problems of compliance if we're giving oral chemotherapy, those sorts of things. This is a patient who's got advanced colorectal cancer. He comes with 2 guards, and even when receiving infusion or chemotherapy, remains handcuffed to one of them. So quite a complicated situation. He is responding to treatment. The prison officers who come with him are well regarded by nursing staff. They do their very best to adapt to the situation that they're in, and they seem on the whole to be I would say respectful and kind, feeling sorry for the patient, that their prisoner that they're looking after. The really good group from King's College in London recently published in Lancet Oncology a survey in which they looked at the outcome for patients who are prisoners, spanning a 20-year period in England. They've used a variety of different public but well-annotated databases, some very sound methodological and statistical approaches. And what they found was quite interesting, that over the period that they studied, there was an increasing incidence of cancer in prison patient populations. But what was perhaps not surprising, but a little worrying, is that there was a significantly lower survival overall in the prison population compared to the general population. The association with survival was partly explained by accounting for differences as to whether they received curative treatment and adjustment for diagnostic routes. Diagnosis tends on the whole to be somewhat delayed. What the implication of this paper was that in this rather understudied, under-researched group, we perhaps do need to heighten and consider how we improve routine cancer surveillance in these individuals who, because of lifestyle, smoking, other environmental problems, do seem to be more at risk than the general population. I'd be really interested in your own thoughts. As I say, we have a neutral approach to treating prison patients. We ask no questions, we tell no lies, and we just get on with it. As I say, we adapt our treatment regimes around compliance, and we tend to often give more intravenous chemotherapy that we feel that we can control more easily than considering, say, oral capecitabine, just with anxieties about compliance in the prison setting. Although, again, we've worked with prison medical officers in which they have taken responsibility for delivering the drugs and so on in that way. I'd just be really interested in your thoughts, whether technical, the delivery of treatment for prisoners. Is there any moral, ethical problem that you have? I have none, but we'd be very interested to hear your own thoughts. As always, thank you for listening. For the time being, Medscapers, over and out. Thank you and goodbye.